yes, we can. Thanks.
Okay, great. So as Linda mentioned, my name is Dana. I'm joined by my colleague Shannon, and we're going to walk you through CAHI's equity stratifiers, and Shannon will go over a case example for modernizing our sex and gender data standards. So over the course of the next 45 minutes, I believe, I'm going to talk more broadly about CAHI's approach to health equity, and I will feature and tell you a little bit about some of the tools we have available through our Measuring Health Inequalities Toolkit, which helps you to essentially implement some of these suggestions for health equity. And then I will turn it over to Shannon, who is going to take you through some of the modernization efforts for the sex and gender standards, including some of the implementation challenges, the results of the provincial and territorial engagement they've done, and clarifying some of the next steps for modernizing those standards. So before we get into it, I'm going to actually define some of the terms that we use. Health equity is the absence of unjust avoidable differences in healthcare access, quality of care, or care outcomes. Health inequalities are those measurable differences in healthcare which may or may not be fair. An equity stratifier, then, is a demographic, social, economic, or geographic descriptor that can identify those population subgroups for the purpose of measuring differences in healthcare. And equitable care does not differ by geography, income, sex, gender, race, or any other characteristics that can be used to identify patient populations. Measuring inequalities across the population subgroups allows us to prioritize differences in healthcare that can be acted on or improved and used to measure progress toward health equity. We know that health equity is a common goal for health systems at various levels. And so some of these tools and some of the discussion that we're going to get into later gives you some practical ways for how this can be brought into the work that you do. So when we think broadly about CAHI's approach to health equity, we know that health equity is a healthcare system goal. There's been increasing recognition that sociodemographic factors such as income, education, language, and gender impact one's health, and in part, that's by influencing their access to and experience within healthcare services. So our approach to health equity is to develop and promote standard equity stratifiers for use in data collection, analysis, and performance reporting. Is to integrate equity measurement in the analysis and reporting to identify opportunities for population health and system improvement, and to develop methods and tools to support health systems in measuring and reporting on health inequalities. So all of these goals, or this approach to health equity, was reflected in the earlier presentation that Anne gave about the data standards, and in the recent presentation from Ali and Christine on some of the primary healthcare data content standards. Why is health inequalities measurement important? Because unless it's specifically measured, inequalities in health and healthcare can go unnoticed by the healthcare system, even as they strive to improve care access, quality, and outcomes. We know that there's also moral implications because Canada has a universal healthcare system. We understand there's legal implications because different population subgroups have protected rights that allow them access to the same level of care. And we also know that there's an economic incentive in the sense that health inequalities cost the healthcare system billions of dollars each year. We also know that you can't improve it if you don't measure it. So we know that equity is a universal goal of the healthcare systems, yet routine equity measurement is often limited. Often referred to as the tyranny of the average. We can see overall gains in population health and health system performance, but these improvements may mask persistent inequalities between population groups. And so performance measurement and quality improvement initiatives need a cohesive measurement plan that captures overall averages as well as the distribution across subpopulations. So at CAHI, we measure equity through sociodemographic variables. We sometimes use record level sociodemographic data, and we sometimes use area-based measures of inequity. So some of the record level sociodemographic variables that we use include sex and gender, race, ethnicity, indigenous identity. You can also see sexual orientation, religious affiliation, or socioeconomic status and education as some of those individual level variables that can be used to understand and measure healthcare inequalities. And you can also use area-based measures of inequity. And at CAHI, we use postal code as the individual level data collection element that we would collect, but then we use the Statistics Canada's postal code conversion files to impute those area-based measures of inequity. So this can be things like socioeconomic status, or more specifically, income quintiles, urban versus rural and remote geographic location, and education. There's obviously pros and cons for both approaches, specifically related to the feasibility and the availability of the data that you have in the particular data set that you're using to do health inequalities measurement. And so some of our earlier work, back in 2016, we brought together a variety of health system stakeholders, planners, researchers, to really prioritize some of those data needs for assessing health equity. So in that circle on the right-hand side of the slide, you can see some of the different sociodemographic variables that were prioritized or that were discussed back in 2016. Then the ones in bold were the ones that we prioritized for developing or working through a standardized approach. So those include income, education, geographic location, sex and gender, and age. Race, ethnicity, and indigenous identity were also included, but they required a little bit more time. So in 2018, we released the Defining Stratifiers for Measuring Health Inequality, which is a report that's available on CAHI.ca that provided some additional conceptual information needed to be able to measure inequalities across those different dimensions. And then in March of 2022, we released the guidance on race-based and indigenous identity data for voluntary adoption within healthcare systems. This particular standard includes 2 data collection items, so a distinctions-based measure for indigenous identity and a race-based data element. It also indicates that community engagement, data governance agreements, and processes for safe data collection and use are essential for the implementation. All of these different resources are found within our Measuring Health Inequalities toolkit. This particular toolkit is available on the CAHI website, and it is tailored to analysts and researchers with varying knowledge and skill sets. The toolkit consists of guidelines and resources organized into 3 phases. So planning your analysis, analyzing your data, and reporting your findings. Across all of these phases of health inequalities measurement, it's important to engage stakeholders, patients, community populations, to really make sure that the inequalities measurement that you are undertaking meets the needs of the communities that it will identify. There's a variety of different resources and tools available in that toolkit, so I encourage you to go and check it out. There's things like analysis plan templates, lit review guidance, SAS macros, R macros to be able to do health inequalities measurement. So there's a variety of different tools that can be used to help facilitate this type of analysis with the data that you have. We recently actually updated the toolkit back in June of 2022. One of those updates included more tailored information on each of the equity stratifiers, and that was in direct response to stakeholder needs, wanting to have all of the information in a concise one location. So those equity stratifier information is included on the website, and it can tell you a little bit more about how we measure inequalities based on age, sex at birth, gender, education, income, geographic location, indigenous identity, and race and ethnicity. Those help to conceptualize how you can bring inequalities measurement into the work that you do. And I am actually going to turn it over to Shannon now, who will give you a bit of a deeper dive on some of those equity stratifiers, specifically around sex and gender.
Thank you, Dana. So next slide, please. Okay, so as Dana noted, I'm going to do a little bit of a spotlight on one of our equity stratifiers, and I'm going to tell you a little bit more about the work that we're doing on our sex and gender data standards. Next slide, please. So CIHI currently uses what we call a two-step approach of using both sex at birth and gender information where available. And this is really the primary purpose of this is to allow us to identify the transgender population. It also aligns with Statistics Canada's standards that were used in the 2021 census of population. So when we were designing our sex and gender data standards, we really worked sort of hand in hand with Statistics Canada to ensure that we were consistent with the work that they were doing as well. So our current standards utilize this two-step approach, but as Simon sort of alluded to earlier, we have heard that the two-step approach might not be appropriate or relevant in all contexts, particularly when the information will be used for both clinical care and health system use. And we've also heard that there might actually be a better way to identify the transgender population and to report on the inequities that they face in healthcare, which remains a big priority for CIHI. Next slide, please. So I'll just walk quickly through our current standards. So currently this is our sex at birth standard. So we define sex at birth as a code that identifies the category assigned to an individual and recorded at a person's birth. I won't read this, it's sort of on the screen there, but you can see the data element is sex at birth, and then our sort of value labels are female, male, intersex, or unknown. So that's sort of the information that we recommend that our databases collect on sex at birth. Next slide. And then we also have a separate gender standard. So we define gender as a social construct that encompasses gender identity and lived gender, also known as gender expression, as a man, woman, both, neither, or anywhere along the gender spectrum. So for that, we collect female, male, another gender. And for this value, we really recommend where possible to include an open text field. So it would be another gender, please specify with an open text field there, as well as unknown and not applicable. Next slide, please. So it's worth pointing out as a bit of a caveat that while these are our current sex and gender data standards, there are some challenges to implementation, and these are not currently implemented in all of our CIHI data holdings. So one of our challenges is that CIHI does receive a large amount of administrative data, which often comes from a health card swipe during patient registration, particularly in the hospital setting. So in order to address this, in April of last year, the gender data element in our discharged abstract database, also known as the DAD, so that's CIHI's largest database and has the inpatient hospitalization records, was relabeled recorded sex or gender to more accurately reflect the data that was actually being collected, which we know is currently a conflation of sex and gender data sourced from the health card. So this is complicated a little bit further by the notion that you can now, in most provinces and territories, actually update your gender information on your sex card. So on your health card. So we know that it really is a mixed bag. So some provinces are probably collecting sex at birth on the health card. Some are collecting more gender. So we just relabeled the data element to reflect that reality. We also know that open text responses, well considered sort of the gold standard, are not practical or feasible in most healthcare databases. And then we recognize as well, especially at CIHI, that when data holdings are updated, there are several downstream impacts that must be considered, including the impact on established indicators and methodologies. And this is really true for something like sex, which is really baked into a lot of our indicators at CIHI. Next slide, please. Okay, so what we've heard a lot. We've been participating in a lot of forums, and we've been actively engaged in this work now for a number of years. So I just included here a little bit of a snippet of some of the things that we've heard in a couple of different settings. So CIHI actively participates in both Canada Health InfoWay's Sex and Gender Working Group, which is co-chaired by representatives from UVic, as well as the HL7 Gender Harmony Project, which has also had fairly good representation from UVic as well. We participate in both of these forums, and in both of these settings, we've heard sort of loud and clear that there are major concerns with collecting sex at birth in a clinical setting, particularly when this information isn't relevant to the actual care that's being provided. We've also heard that some transgender and non-binary individuals feel harmed or unsafe being asked questions about their sex at birth and or sex for clinical use. On the other side of the coin, CIHI has a survey called the Canadian Patient Experience Survey for Inpatient Care. And this survey currently includes both a sex at birth and a gender question with an explanatory preamble. So because it's a survey, there's actually sort of room to kind of give a little bit more context about the data that's being collected. These questions are asked directly to patients once they're discharged from hospital, and they're not supplied from administrative data. So asking patients directly rather than sort of taking that swipe of the health card. And we actually found that the questions tested quite favorably during cognitive testing. So we didn't hear the same concerns about collecting sex at birth, and patients felt that the preamble was clear and that it may influence others to answer the questions. Next slide. So what sort of has become more clear in our mind as we participate in these forums and work with our partners on this is that perhaps there isn't really a one-size-fits-all standard for sex and gender. And we might need to consider implementing our sex and gender standards differently in different contexts. So perhaps a two-step approach for collecting sex and gender data might work in the context of surveys, like the patient engagement survey that I just mentioned, where a really clear preamble can be provided before the question is asked. But maybe we might need a different implementation of the standard in the clinical portion of an EMR or an HIS. That's electronic medical record or hospital information system. And perhaps even a different implementation in the administrative or registration portion of that system. And then we're doing a lot of work right now on health workforce data. So maybe we might even need a different implementation in systems that collect data about providers or health workforce resources. So I think the context here is really important, and it's really important to consider sort of why we're collecting the information. The good news is we have many willing external partners who can help us resolve this topic by bringing different expertise to the table. Next slide. Okay, so I'm going to pivot a little bit and go over some of the results that we've recently done. When we were sort of thinking about our sex and gender standards and the next steps, we realized that we really needed to reach out to a number of different groups, but we started with the provinces and territories as well as some of the software vendors. So next slide. So with the support of an external consultant, CIHI engaged with the provinces and territories, as well as some of the major EMR and HIS software vendors, to better understand the sex and gender data that's currently being collected within the jurisdictions, including the flow of information between the systems. And it's worth mentioning that this was actually an update to an environmental scan that Canada Health Infoway had completed in 2019. I believe that scan was primarily conducted with information that was sort of readily available online, whereas we actually went out and we booked sessions with each of the provinces and territories with the goal of updating that scan. So we conducted 12 one-hour interviews with provincial and territorial stakeholders to gather input on the current state challenges and opportunities for the collection and use of sex and gender data standards in their jurisdictions. You'll notice that there is one PT missing there. We never were able to secure a meeting with Prince Edward Island, but luckily the consultant that we were working with had some connections within the province. So I think we were able to obtain the information that we needed. We just weren't able to book an actual engagement session with them. And then we developed structured questionnaires and surveys to help guide the engagement. Next slide, please. So this is a very busy slide, but I think it really sort of shows the key findings from our consultations about what sex and gender data is being collected. And as you can see, it is a complete mixed bag. We expected it to be a mixed bag, but I think it was even more inconsistent than we imagined. So you can see it along the top of the screen are the provinces and territories, and then in sort of the shaded green on the right-hand side, those are the major vendors who we heard from as well. We offered the vendors to also sit down and chat with us for an hour, but they did not take us up on that. But luckily, these are the ones who answered our surveys, and we were able to get actually a lot of information via that route as well. So you can see that for sex, all of the provinces and territories collect male, female, or unknown. The way that they actually define sex is a little bit different. So some call it sex at birth, some call it legal sex, some call it administrative gender. But fairly consistently, everybody is collecting male, female, and unknown, and then things start to get a little bit dicey. Gender is even a little bit more dicey. So you can see that for the Yukon and the Northwest Territories and some of the provinces towards the right-hand side of your screen, they're actually not collecting any gender data at all. And then some of the jurisdictions that are collecting gender data, the information that they're collecting is very different from jurisdiction to jurisdiction. So next slide, please. So some of our key findings, I've touched on some of these already, but overall there was a lack of standardization of sex and gender data capture and use, both within and across provinces and territories. So some provinces that had sex and gender data standards, it even, depending on the system or sort of the environment that they were using it in, it even sometimes differed within the province and territory. The definitions varied greatly, as did the collection processes and use for administrative, clinical, and analytical purposes. Some provinces captured structured gender data, but generally only in one system or jurisdiction. So for example, in the provinces that have health regions, such as British Columbia, sometimes we would find that only one health region was collecting that information and it wasn't being consistently collected across the province. And then we found that the processes for collection of sex at birth or legal sex were similar across most of the provinces and territories for vital statistics reporting, and registration processes for health care insurance cards. So people were collecting that information fairly consistently, but how they used the information in downstream workflows was really different across provinces and territories. And in some of the provinces and territories that we spoke to, we actually heard that it's extremely difficult to change because they actually have legislation that dictates exactly what needs to be collected for vital stats reporting. Next slide, please. So here's just some common challenges that we heard from our participants. So system limitations came up a lot. They recognize the value of this work. They really want to make sure that they're collecting the most accurate and safe sex and gender data information, but they're really being limited by the systems within their jurisdictions. A lack of standardization of concepts, names, definitions, and values across systems. People refer to having sort of like no source of truth for this information. Lack of lived experience input into the requirements for sex and gender information capture came up a lot. And it was also noted that clinicians and frontline staff lacked the training and education on how to ask potentially sensitive questions. And then another thing that came up was patient or client lack of trust in government agencies and the potential use of sensitive information. So, you know, patients ask, like, why do you need to know this? How is my information going to be safeguarded? And this particularly came up within the territories. So I just included a quote on the right-hand side of the slide from one of our participants in Newfoundland and Labrador. And this is something that really resonated with me. So she said, you know, there are so many different standards groups with so many different standards, and we're constantly struggling to keep up with who is doing what. So I think there's really a need here for some sort of pan-Canadian coordination for sex and gender data standards. So next slide, please. So I'll just touch quickly on the vendor engagement as well, because we found a lot of the same things, but there were some sort of unique findings as well. So we did find that all of the vendor solutions captured some form of sex, so whether it be sex at birth, legal sex, or administrative gender for administrative purposes. As I noted earlier, male, female, and unknown were common values, and then other values varied across solutions. And we also found that all vendor solutions except for one enabled the capture of structured coded values for gender, but the only common values were male, female, intersex, and two-spirit, and all other values varied across the solution. And vendors expressed that they would be open to adopting a national standard within their databases, but cautioned that local customer requirements may supersede this. So this is a bit of a red flag for interoperability, but it was something that the vendors were pretty honest with us about in their survey responses. Next slide, please. Okay, so in terms of next steps, next slide, please. We are planning to continue to engage in a number of different standards forums. So with the HL7 Gender Harmony Project, with ISO, and with Canada Health Infoway's Sex and Gender Working Group. We recognize that there are a lot of groups doing really good work within this space. So we're planning to sort of build on that and leverage it where necessary and contribute to that work as well. And then we are hoping to do some additional engagement. So we know that we need to reach out to individuals with lived experience for their sort of input into these data standards, as well as Indigenous partners and clinicians and researchers. And then we also want to continue working with our partners to determine the best way to identify transgender individuals in our data so that their experiences can be accurately represented. So for example, if we do decide to move away from collecting sex at birth in a clinical setting, we want to make sure that the data that we do collect allows transgender individuals to be identified, because we know that their interactions with the healthcare system can be unique, and we want to make sure that they're represented in our data. The next slide, please. So on our end, some concrete next steps. We're planning to initiate the process to update CIHI's sex and gender data standards to include a variable called recorded sex or gender. So this will be data sourced from the health card. And this aligns with the current HL7 gender harmony standards in V2 CDA and R5 of FIRE. And it also, as I mentioned earlier, while not perfect, is sort of an accurate representation of what is being collected in a lot of cases. So our real goal with that is just kind of to accurately label the data that we do have while we continue to sort of make progress on collecting more modernized sex and gender data. We want to work towards standardizing the gender identity values and continue working with Canada Health Infoway and with Statistics Canada to determine what the eventual governance of these standards will look like. And then I just threw in the last bullet here, progress is better than perfection. And I chose this image rather intentionally because it really is quite the mountain to climb. But I like to think of that person at the top to be all of our partners and all of the Canadians who are really invested in this work. So we know that we're not doing it alone, and there are lots of dedicated people working on this together. Okay, that is it for me. I guess we can open it up to questions for either Dana or myself.
Absolutely. Thank you so much, Dana and Shannon. Does anyone have any questions for either Dana or Shannon?